Hi everyone, I want to talk about tuberculosis treatment. Tuberculosis treatment. Before you can enjoy this presentation, I will advise that you check out my channel for all other TB presentations that I've published. But today, it will be all about treatment of tuberculosis, and we'll adopt a system that the World Health Organization has approved, which is DOT, meaning directly observed therapy. With that, let's go. DOT, meaning directly observed therapy, is the pattern of treatment when it comes to tuberculosis that involves administration of medication directly to the affected individuals that will be on treatment, observed by the physician or the nurse. That could be done daily, 7 days per week if hospitalized. But you have the luxury of 5 days per week if the patient is not hospitalized. So the patient can come to the hospital or the clinic, and the clinician or the nurse will administer the medication directly and check the record, mark it somewhere, and allow the patient to have self-administration on weekends. But if you are suspicious that this patient may not self-administer the medications over the weekend, then you can switch back to every day, like as if the patient is hospitalized. Directly observed therapy. When someone is newly diagnosed with active pulmonary tuberculosis, the individual should have INH, that is Isoniazid, with Rifampicin, depending on the trade name, could be Rifampicin, could be Rifabutin, could be Rifampin. But let me go back. Newly diagnosed pulmonary tuberculosis should receive INH, Rifampicin, Pyrazinamide, Ethambutol, and you add Pyridoxine on top of that daily for 2 months. Then you reduce the medications to 2 with Pyridoxine for the next 4 to 7 months. That is, you take off Pyrazinamide and Ethambutol and leave the patient with INH and Rifampicin, but because of the neuropathy associated with INH, other name is Isoniazid, you place the patient on Pyridoxine. So somehow the patient will be taking 3 medications every day for the next 4 months, but maybe up to 7 months. So in total, you'll be treating the affected person with active pulmonary tuberculosis for 6 to 9 months. The first line agents are the ones that I've just mentioned in the last 2 minutes: Isoniazid or INH, Rifamycin, depending on the pharmaceutical company and the trade name available at the jurisdiction. So Rifamycin, Rifampin, Rifabutin, Rifapentine, or Rifampicin. So they are all the same, depending on the manufacturing company with the different trade names. So INH, Rifampicin, Pyrazinamide, and Ethambutol. Those are the real antimicrobial agent. But we add Pyridoxine, that is vitamin B6, to save the affected person taking all this medication from the horrible side effects of polyneuropathy of INH. Doses. I'll just briefly go over some of them here. Isoniazid or INH could be given in form of injection or tablet from 50 mg to 300 mg once daily, or could be injection or tablet at 15 mg per kilogram 3 times per week. The reason why I brought it down to milligram per kilogram is it depends on the age. Not all the affected people will be adults. Sometimes children are affected. It could also be injection or tablet 15 mg per kilogram 2 times per week or 1 time per week. Rifampicin could come in form of capsules or injection given at 10 mg per kilogram, but the maximum you can give is 600 mg daily. So sometimes it could be administered 3 times per week or twice per week or 1 time per week. Depends on the assessment of the treating physician in consultation with TB experts. Still on doses. Rifabutin come in form of capsule only for 150 mg to 300 mg per hour once daily, or Rifapentine capsule 150 mg once daily or 10 to 20 mg per kilogram once weekly. Pyrazinamide could be given as 500 mg to 300 mg per hour once daily, depending on the weight. Ethambutol could be given as tablet 800 mg to 2,400 mg, that is 2.4 grams once daily, depending on the weight as well. Okay, the second line agents. Someone will ask me, why second line agents? Well, we need to go over this because it's not all the time that the first line agents that I've just discussed will do everything for the affected patients. So we need the second line agents, particularly if we're dealing with multi-drug resistant tuberculosis. Then we have to do microscopy, culture, and sensitivity. If you want to know more about that, you can check my presentation on TB screening and diagnosis. We can use up to 5 drugs that the microbe is susceptible to based on the outcome of microscopy, culture, and sensitivity. But I need to say here that when we hear the word drugs, in North America, that may mean street drugs like cocaine, amphetamine, and so on. But in many other Anglophone countries, drugs may mean the medication that North Americans would call medications. Like in the context of this presentation, in North America, it will be medications, but in other Anglophone countries, it will remain drugs. So we can use up to 5 medications or drugs depending on where you are on the surface of the earth. We can use those that have not been used in this patient. Do you know why? That will give us more peace of mind that you are double sure these patients will not likely be resistant to this, except he or she has acquired the organism with strain that is already resistant to that particular medication. And consult your TB experts. And of course, I've written here, you can choose from, and someone is looking, choose from what? Don't worry, the next slide, you will know what you can choose from. Yes, you can choose from fluoroquinolones, Levofloxacin, or Moxifloxacin. But here is the warning. We don't give this to a pregnant woman or a breastfeeding mother. No. You can use both Linezolid and Bedaquiline together, and you can also use both Clofazimine and Cycloserine, or Clofazimine and Terizidone. But you don't use Levofloxacin and Moxifloxacin together. No, just choose either Levofloxacin or Moxifloxacin. but you can combine Linezolid and Bedaquiline, and combine Clofazimine and Cycloserine, or Clofazimine and Terizidone. Use only either Amikacin or Streptomycin. They are both aminoglycosides. You don't need to combine the two. If you can use injection in D above, which is if you can use Amikacin or Streptomycin, then you can use Delamanid and Pyrazinamide and Ethambutol. You can also use Etonimide or Protonimide, Imipenem with Cilastatin and Clavulanate, or Meropenem and Clavulanate. Pre-aminosalicylic acid could be used, and you can use high-dose Isoniazid. Bedaquiline will be very useful, particularly if you have identified the case to be multi-drug resistant pulmonary tuberculosis or extrapulmonary tuberculosis. Monitoring. Now, I'm not a military officer, so why monitoring anyone? I'm not a police officer, why monitoring anyone? Well, I'm sorry. When it comes to treatment of tuberculosis, we monitor. We need to monitor the serum concentration of the anti-tuberculosis medications that have been administered. Remember, again, the reason why I didn't use the word drugs is in North America, drugs mean something else, right? But in other Anglophone countries, drugs means medications. So we need to know the serum level so as to facilitate the dose adjustment. But monitoring will be required if there is drug-resistant tuberculosis. If there is relapse, you want to know, have I given enough dosage before you label this situation as being drug-resistant, or the relapse we are getting right now, is it my fault because I'm not using the adequate dosage? You can now confer with your pharmacist and, of course, the TB experts, your jurisdiction. Or you discover that there are no clinical responses. Then you start monitoring. What is going on? Have I given the right medication? I will give a true life story here. I remember we were in the medical school and having ward rounds. And we were going around with the consultant, the senior registrar, and the registrar, including the interns. And of course, I was still in medical school that time. And we had a patient, a TB patient, on Rifampicin. And we were not getting clinical response. And the consultant was asking us, okay, can you rattle in your brain why we're not getting responses? People were saying all sorts of things. And one of my classmates said something, and I've never forgotten. And he said, "Sir, is it possible that this patient has taken fake medication, fake drug?" And we were like, "What?" And the consultant said, "Oh yeah, that could be possible." Then the questions were thrown at the patient. When the TB patient is on Rifampicin, it's going to change the color of the urine. And then the patient was asked, "Do you notice any changes in the color of urine?" And the patient smiled and said, "No, it's normal." "No, is it turning pink or red?" And then, "No." Then, the consultant said, then we need to do something else. So the consultant laid down his own personal money that another cell of Rifampicin should be bought from another pharmaceutical store within the city, and that they should administer it, and the second day, check the urine. Lo and behold, some of us were so anxious to know the outcome. I was there the first thing in the morning to find out it was true. The guy had been on fake Rifampicin, and this is common in some parts of the world. Then you are going to monitor the level if there is drug malabsorption, particularly individuals that are boozing a lot, using alcohol, okay? If this patient is having diabetes mellitus with gastroparesis, you need to monitor. If you are suspecting drug-drug interactions, you need to monitor, particularly those enzyme inducers. Of course, if there's renal impairment, that excretion will be decreased, and you don't want to overdose the patient because there is maximum dose per day, right? You need to know what the renal clearance is, glomerular filtration rate. How about HIV co-infection? And of course, the use of aminoglycosides. You can't just use aminoglycoside indiscriminately because you'll be treating the affected person to ototoxicity and nephrotoxicity. And of course, the side effects that the patient will be presenting with will warrant you monitoring the level of those medications. Before administering TB medications, you have to do some basic laboratory investigations. Liver function tests, check the bilirubin level, clotting factors, clotting profile, check the glucose level and liver enzymes, AST, ALT, ALP, you check all of them. You might or might not check for antigens for hepatitis B and C. You can screen for HIV. In fact, except the patient refuses, and of course you should pass that to your superior, you have to screen for HIV in anyone diagnosed with TB nowadays, because HIV will make your work to become unproductive. It's going to worsen the situation. So screen from the beginning. In some parts of the world, you don't need to sign anything. You just grab the patient and then screen. But in so many parts of the world, in industrialized nations, Western countries, the patient must give consent before you can screen for HIV. So if they're refusing, then let the superior know about that. Complete blood count, blood urea nitrogen and creatinine. I've just explained why renal impairment can affect the level of the medications. Of course, pregnancy test in any woman of childbearing age, because you don't want to treat the woman into having a child that will be deformed because of teratogenicity, right? The effect of the medication on the developing fetus from zygote and so on. Visual acuity, of course, ethambutol will give visual problem. And of course, serum function tests, particularly those that will be taking ethonamide. And you rule out depression because cycloserine might have psychiatry and situations as side effects. Neuropathy, INH and Linezolid will give neuropathy. That is why we'll place the patient on Pyridoxine. And of course, Bedaquiline and quinolones are not so friendly on cardiac electrical system. So you need to have your EKG, because you might be dealing with cardiac arrhythmia, long QT syndrome, and cardiotoxicity. So we want to administer Bedaquiline or quinolones, have your pre-med EKG done. While on anti-TB medications, advice. You can't force anybody, but advice. No alcohol. And watch for signs and symptoms of hepatotoxicity, like nausea, vomiting, dark urine, jaundice, pruritus, fatigue, fever, bleeding, bruising, right upper quadrant pain, or arthralgia. You need to watch out for hepatotoxicity, and of course, I've given the signs and symptoms in the last slide. And of course, watch out for peripheral neuropathy when you are placed the patient on Isoniazid, Etonimide, Cycloserine, or Linezolid. Therefore, you give B6, that is Pyridoxine, at 50 mg per oral once daily. Let me leave this. Even Pyridoxine, if you give it too much, if you give too high dose, then you are going to lose the purpose for administering the same medication. Pyridoxine on its own, at very high dosage, will give the same neuropathy you are trying to prevent. Yes, confirm with the pharmacist. And of course, central nervous system toxicity like seizures, psychiatric effect, or serotonin syndrome. If you check my channel, I have published a presentation on Linezolid. I tagged it reserved antibiotics. It's doing two jobs. It's both an antibiotic and antidepressant. So check out. I will not waste your time going into details here again. Then you need to watch out for ototoxicity with aminoglycoside, the same as nephrotoxicity with aminoglycoside, and ophthalmic toxicity with ethambutol. That's why you need to check for visual acuity before placing the patient on ethambutol. But the ethambutol is not the only medication that could give ophthalmic toxicity. So Linezolid, Etonimide, Isoniazid, and Clofazimine could give the same. Therefore, let the affected individual taking these medications be on monthly ophthalmic monitoring. Watch out for musculoskeletal joint pains, hypothyroidism if the patient is on para-aminosalicylic acid or etonimide. Check the glucose level if you have placed this patient on Linezolid or quinolones. Flu-like symptoms is very common with Isoniazid, Rifampin, and Rifapentine. Handle anaphylaxis appropriately. You can get your EpiPen, particularly if you are administering the medications for the first time. And never repeat the same medication that would have triggered the anaphylaxis. And with that, I've come to the end of the presentation on TB treatment. I've gone through all the available medications that we are using at this present generation. Things may change in the next few years, and all the side effects that I've mentioned during this presentation will not be the end of it. You can go on your memes or anywhere online to find out more side effects of each of these medications, or if time permits, in future, I will take each of these medications and deal with all the possible adverse effects from A to Z. With that, kindly remember to subscribe to my channel, share this with all your colleagues and friends and patients that are taking all these medications. My heart goes out to everyone and wishing the affected people well. Thanks. Bye for now.